webinar series with Joyce Yu. I hope you can all hear me. I just have a couple words of introduction before we get started. We're really excited about these two cases. They are totally fascinating. I want to remind you that this webinar is supported by the Clinical Immunology Society, USIDNet, and LaCide. And if you are not a member of the Clinical Immunology Society and you are a trainee, your membership is free, so there's really no reason not to be a member if you're a trainee. And the other thing I want to mention is that we are looking for more cases for this webinar series. So if you have an interesting diagnostic case or a case that presents a management conundrum, I'd be very anxious to hear from you. So please feel free to email Joyce or myself, Kate Sullivan. And with that, I'm going to introduce the speakers today. We have case presentations by Carolina Prando and Mike Keller. And we have two mentors from the outside, Tamara Pozos and Alexander Freeman. We're really grateful for their insights today. And then Joyce Yu is going to start off, as usual, with a brief literature review. So I'm going to turn it over to Joyce, and then we'll hear about her impressions of her favorite papers from this past few months, and then we'll have the cases. Take it away, Joyce.
Thank you, Kate. So let me just open up my slides. Hope everyone can see it. Great. So tonight for the literature review, I'm going to review 3 articles from the JOCI. So the first article I wanted to review is the extended clinical phenotype of 26 patients with chronic mucocutaneous candidiasis due to gain-of-function mutations in STAT1. So as we all know, autosomal dominant CMC is often associated with mutations with STAT1. There are other genetic mutations associated with this, but STAT1 is the one that's most frequently associated. The theory is that with the mutation, it leads to hyperphosphorylation of the STAT1 protein, resulting in decreased IL-17 T cells, and thus resulting in an impaired immunity to Candida. The authors of this paper wanted to assess the frequency of the gain-of-function STAT1 mutations, as well as the clinical phenotype in a group of CMC patients. They looked at 57 CMC patients, as well as 57 healthy controls. 39 of the CMC patients were familial CMC, and 18 of the patients were sporadic. So what they found was that 61%, so 35 of the 57 patients, had a heterozygous mutation in STAT1. So that basically accounted for the majority, like 80% of the familial mutations, and about half of the patients with sporadic mutations. They identified 13 mutations, 5 of which were novel. 7 were in the coil domain, and 6 were in the DNA binding domain. Of the patients who did not have a STAT1 mutation, they did not find mutations in the other genes that are listed here. As for the healthy control family members, the majority did not have a mutation in STAT1, although there was one female carrier of a STAT1 mutation that was actually passed on to her children who had CMC. Functional studies were done in these subjects, which showed that there was indeed an increased STAT1 phosphorylation, after interferon and or IL-27 stimulation. There was, interestingly, one subject with a valine to isoleucine mutation in STAT1, but was not found to have an associated change in the functional phosphorylation of STAT1. So this patient was excluded from the subsequent studies analysis of the clinical features. In terms of clinical features, as to be expected, the oral fungal infections were the most common, especially esophageal candidiasis and aphthostomatitis. Most of these patients were definitely treated with several courses of topical and systemic antifungals. However, one of the features that were noted was that the disease tended to be very recurrent and persistent, even despite recurring treatment courses. In the females, vulvovaginal candidiasis was very commonly seen. Other features were intertrigal, pustules, onychomycosis, and paronychia, as well as just regular typical infections such as bronchitis and sinusitis and pneumonias. Some patients did have herpes and human papilloma virus infections. 2 patients were interesting noted to have cerebral aneurysms, of which one was found to have an associated cerebral vasculitis. and a large number, about 44% of the patients, were noted to have hyperthyroidism, particularly with elevated TSH levels. In terms of immunologic features, the lymphocytes and the immunoglobulin levels were generally normal in these CMC subjects, but about half were noted to have decreased NK cells as well as increased IgA levels. So what these authors recommended was that because so many CMC patients, majority actually has STAT1 mutations, they do recommend to routinely consider routinely sequencing the STAT1, as well as possibly performing functional studies in all suspected autosomal dominant CMC patients. Of course, they do acknowledge that of the remaining 39 patients or subjects who did not have a mutation in STAT1, those subjects still need to be in need of further workup to determine their cause. So that's the first paper. The second paper is the 11q terminal deletion disorder, Jacobson Syndrome, is a syndromic primary deficiency. So Jacobson Syndrome is associated with a partial deletion of the long arm of chromosome 11. So it's a syndrome associated with several features: growth retardation, developmental retardation, dysmorphisms, thrombocytopenia, as well as pancytopenia, various organ malformations, hearing, ocular, and endocrine problems. And there have been various sporadic case reports showing that there are immunoglobulin deficiencies or antibody deficiencies, specific antibody deficiencies, as well as case reports of lymphopenia. So what the authors of this paper wanted to do was to assess a series of subjects with Jacobson syndrome to determine whether immune deficiency is indeed a common feature of the syndrome. So they looked at patients that were ages 6 to 35 years, 4 females, 2 males, and they found that in terms of clinical features, there's definitely a strong feature of recurring upper and lower respiratory tract infections. And of the ones that were cultured, H. influenza as well as strep pneumo were identified. Interestingly, there was one subject that did not have a history of infections coming in. Unfortunately, there were limited studies of their lungs, so in terms of whether other lung issues such as bronchiectasis or other lung issues were unknown, given the lack of information. There were no reports of recurring skin, gastrointestinal, or urinary tract infections. There was one patient, interesting, with multiple warts, but no history of autoimmunity or malignancy reported in this group of patients. And 2 of them already had come into the study already on immunoglobulin replacement. In terms of the immune features, the majority did have hypogammaglobulinemia, anemia, so low IgG levels, as well as a variable decrease in IgA and IgM. A large number of them, or most of them, are 5 out of 6 in the small group, were noted to have low B cells, and in particular, they were noted to have very low number of memory B cells. However, there was some variable decrease in T cells and NK cells as well. They did have low specific antibodies to strep pneumo, as well as decreased vaccination responses. So based on these recurring features that they found in these patients, the authors proposed that the Jacobson syndrome be considered as a syndromic PID, almost similar to, say, Down syndrome, and suggesting that perhaps all Jacobson syndrome patients should be evaluated for primary immunologic defects. And the last paper I wanted to review was the FAST haploinsufficiency caused by extracellular missense mutations underlying autoimmune lymphoproliferative syndrome. So ALPS is most commonly due to heterozygous mutations in the intracellular domain of FAST. So because of this mutation, they can't form the trimer, so the receptor is expressed, but because the trimers cannot form, they cannot function. However, about 1/3 of patients with ALPS do have a nonsense mutation in the extracellular domain. And even further, there have been noted 12 missense mutations described in the extracellular domain. However, it's unclear how these missense mutations result in the ALPS phenotype. So in this paper, the authors basically studied the pathophysiology in about 7 patients with this particular missense mutation, the C107Y missense mutation, and 5 who had a heterozygous phenotype, so mild disease, and 2 homozygous siblings with very severe disease. So the first thing they note was that FAS is not expressed at the cell surface in these patients with this particular missense mutation. They found that the FAS-induced apoptosis was reduced in the heterozygous patients and completely absent in the homozygous siblings. In addition, the cell surface FAS expression was reduced in the heterozygous patients, but completely absent in the homozygous patients. However, when they did intracellular staining and permeabilized the cells, they found that total amount of FAS expression was actually similar to controls. So what they did next was to transfect the HEK293T cells with these two different mutations, so the C107Y as well as another missense mutation, the C104Y, and they found that these transfected cells did express FAS, but it was not at the cell surface. So what they did next was to find that the mutations, these particular missense mutations, potentially cause retention of these proteins in the ER, which is why they don't get to the cell surface. So they found that in the transfected cells, there was co-localization between the mutated protein and the ER-specific fusion protein based on the confocal microscopy. And they found that these cells were susceptible, the gels, that the proteins were susceptible to endo-H digestion, suggesting that they were actually retained in the endoplasmic reticulum. So they proposed that based on this information, that probably the glycosylated retained FAS protein probably could not be folded correctly and therefore could not be transferred to the Golgi to go to the cell surface. The authors also hypothesized that perhaps this mutated FAS, which is retained in the endoplasmic reticulum, perhaps does not necessarily accumulate in the ER, causing cell stress. And the reason why is because they didn't see any increase in the BIP stress protein expression, suggesting that perhaps maybe whatever is retained in the endoplasmic reticulum is actually subsequently translocated out to the cytosol and eventually degraded. They also note that perhaps in some of the heterozygotes here, in terms of the ones who had the milder mutation, milder phenotype, that perhaps there was a contribution of a second mutation in FAS, and I believe they actually noted this in 2 of the 5 patients, and they also suggest perhaps maybe other environmental factors may be affecting the penetrance in the heterozygotes. So that's it for the LET review. That's it. Thank you.
Joyce, that was really amazing. Thank you so much. Well, the first case comes up, which is Carolina Prando. I just want to comment on that STAT1 paper. I've been really surprised at how common STAT1 is in chronic mucocutaneous candidiasis. It's far and away the most common single gene defect. And I guess I wasn't prepared for that. I thought that some of the more candida-specific genes like IL-17 would end up being it. So it's been a pretty consistent finding from the Casanova group that STAT1 is far and away the most common single gene defect. Really, I think not what many of us expected. So I'm going to introduce Carolina Prando. Carolina is from, I actually read so that we wouldn't give away the ending. It's a really, I think you're going to find it very interesting. Carolina, please go ahead and get started.
Okay, so good night to everyone, and thank you, Kate, for the opportunity to be here. So we can, we'll be talking about a boy. He's 10 years old now. He's born from non-consanguineous parents from southern Brazil, from the city where I work, that's called Curitiba. So this boy had his first sign of infections when he was 6 months old. So he presented bronchiolitis that didn't have any special features and evolved very well. But then since his 6 months of life up to 2.5 months, he presented 4 hospitalizations to treat respiratory infections, pneumonia, and also sinopulmonary infection. He went to surgery to remove his adenoids, and he also had 3 infections caused by rotavirus, and he had to go to the hospital also, to be in the hospital to be treated. One of the diarrhea episodes, the mother tells us that they identified some kind of fungals, but she doesn't know which one, and she doesn't have the exams for us to check. So by this age, 2.5 years, the physician that was following the patient asked for immunological evaluation in lab tests, and he identified the patient presented with low IgG and low IgA. He had normal leukocyte counts, and he presented with IgM of 720, so a very high level of IgM.
Carolina, this is Tamara. Did he have good responses to his vaccines at that
point?
Oh,
yeah, so I didn't put it here, but no, he didn't have a good response to vaccines. He was not evaluated by this time, but later on, when I started following him, I checked, and he didn't have any response to the vaccine that he received.
So what are people thinking about this presentation? This is sort of an unusual set of laboratory features. Are you thinking about a particular diagnosis? You can go ahead and use your chat function to tell us what you're thinking.
Okay, so we have one hyper IgM, one more hyper IgM. Okay.
So, Carl, I don't think you can read too much into the title.
Okay. So can we move forward?
Yes.
Okay.
We've got people thinking. They're definitely imagining various hyper IgM scenarios. So go ahead and tell us how it unfolded.
Okay, so after this diagnosis, the child was started receiving IVIG, and with this immunoglobulin replacement, even though he did not go well. Hello?
You're fine.
Okay, so even receiving immunoglobulin, he was not doing well. So he kept presenting with infections, sinusitis, otitis with a suppurative form of ear infection, pneumonia, and then he was put on prophylactic antibiotic. And here I think it's important to say that the IgG level was kept pretty high, so it was not a fact of increasing the dose of the immunoglobulin, for example.
And was he having unusual exposures? Could you chalk up his breakthrough infections to just having a very large exposure, or there was not really an obvious explanation at this time?
No, there was not an obvious explanation.
Okay, does anyone want to change their diagnosis based on this?
Yes, they didn't. So by that time, when he did the surgery to remove his adenoids, it was like more than 8 years ago. I was not following the patient, and they didn't look at the pathology. So, and I couldn't recover the sample to study it.
Okay, so people are definitely thinking about expanding the diagnosis past classic class switch. Why don't you take us through what happened next?
Okay, so then as the patient presented at that time a very clear history and phenotype for hyper IgM, even though he was not responding very well for the treatment, the samples were sent to the laboratory of Professor Antonio Condino in São Paulo by the year of 2008-9, something like this. And then they looked at the expression of CD40 ligand, and he expressed 95% of the cells expressed CD40 ligand. for CD4, even though he had very low levels of B cells, all of them expressed CD40. And they found a polymorphism on exon 5 for the CD40 ligand gene. So I'm looking for the chat questions here. Okay, so T cell function were not evaluated by that time. And he did not present with lymphadenopathy and hepatosplenomegaly by this time, when he was like with the age of 3 up to 6, 7 years. And the MBL levels were not tested.
So David, I think, is maybe thinking about AID deficiency as a cause, which is classically associated with hepatosplenomegaly and big adenopathy. And Carolina, I have to ask, because I don't know the answer, is CD40 ligand flow very sensitive for the mutations, or are there a fairly large number that express protein but are still dysfunctional? Do you know?
I don't have this answer, but what the patient has for these results were just the expression, and for the sequence, they only found the polymorphism on exon 5. Okay. But I don't know if even having the chat
room know how sensitive CD40 ligand flow is. I think it might be a useful thing for people to know. If you know, just type it into the chat box. Go ahead, Carolina, and tell us how it unfolded.
Okay, so in the meantime, while they were testing for CD40 and CD40 ligand, the patient kept presenting with infections from the time of the hyper IgM diagnosis up to 7 years old. And when he was 7 years old, he developed a Hodgkin lymphoma. So during 1 year, almost 1 year, he received a chemotherapy and radiotherapy, and he recovered pretty well from this lymphoma.
So this is an unexpected turn of events, right? What do people think now? Do you want to change your diagnostic considerations? Go ahead and start typing in what you think is going on. Although lymphoma is seen in the class switch deficiencies, does this make you change your mind?
Okay, some people already changed their minds here.
I guess they did.
Yes. And should I just keep presenting the case, or you want to comment anything else here?
I think people are definitely reforming their ideas and moving in a good path, but not the perfect path. So go ahead.
Okay. So when I first saw this patient was like 1 year ago, and so with this, even though with all this picture, it was beginning of last year when I started seeing him. So I decreased the interval for IVIG to 21 days, and he had a pre-infusion level of IgG of 946. So I think it was pretty good. And I started him also on antibiotics, on sulfamethoxazole plus trimethoprim. Then I looked for flow cytometry for the CD4, CD8, and CD19 cells, and he had a low CD4 and low CD19 cells. I'm going to show you in the next slide. And by this time, he didn't present an IgM of more than 700, but he had an IgM of 81. So we have here a boy that never got free of infections, even when receiving immunoglobulin replacement and antibiotics. He developed a Hodgkin lymphoma, proved EBV infection, T and B cell lymphopenia, and he presented with normal expression and a wild type sequencing for CD40 and CD40 ligand.
All right, I'm looking for some diagnoses.
Sorry?
We definitely have Well, we definitely have people thinking down some new paths here.
Yes.
Someone wants to know what the natural killer cell numbers are. I don't think I saw that.
Yeah, so we have it here. So we decided to study further for the immunophenotype of this patient. And here we have the picture for the T cells. So we see that we have like 335 CD4, and for CD8 we have 1066. And people asked for the CD45 RA plus. So we have it here, CD4. So it's 10.5%, and the absolute number is 269. And for the CD8 cells, the equivalent in CD8 cells, we have the CD27 minus, CD45 RO minus, and CD8 plus cells. We have a number of 614 cells. For B cells and NK cells, the patient presented with 38.4, 1.5% of B cells, and NK cells 360.
So that's a little unsettling, right? Like for a classic class switch recombination defect, your B cell numbers should be normal. So now he has been treated for Hodgkin's. Maybe there's some lingering effects of that treatment. Carolina, these tests are a couple years after the Hodgkin's treatment, is that right?
Yeah, it was almost 2 years after the treatment.
You wouldn't think there would be much leftover toxicity, but I suppose it's possible. So now,
but Kate, earlier I will go back on the slides, and we see that he presented with here. He already presented with B-cell lymphopenia by the time he was first examined for hyper IgM syndrome.
All right.
So it's not something that he developed after the treatment.
All right. I think Carolina's getting ready to reveal the diagnosis, so now is the moment to put in your votes. I see there are some people asking about INKT. I'm curious to know about that, since I think of INKTs and sort of SAC deficiency or SH2D1A deficiency. Is that useful in, I'm genuinely asking, is that useful in this scenario?
Can you repeat, please? I missed your...
Some people are asking about INKT cells, Mike Keller specifically, or natural killer cell numbers.
Yes, so we have it here. It's the, let me find it here, 266.
Okay, so good numbers of natural killer cells. We don't have INKT cells, but again, that would be more down the SAC deficiency pathway. So, audience, this is your time to vote for a diagnosis. You've talked about a lot of different options. Classical class switch recombination defects. We went down the NEMO pathway. I'm trying to scroll back through some of the comments. We have PI3 kinase C delta. We have a few votes for that. And then we have some people more focused on T-cell stuff. I'm not sure you want to stay wedded to that now that you've seen the T-cells, but please go ahead and start voting.
Okay.
So go ahead and put in the chat box. You have to declare. It's not fair to hide. So go ahead and start getting to your diagnosis here. So we've got a NIC deficiency. That's an interesting thought. I wouldn't have gotten there myself. We have a few people who have talked about T-cell defects, and this being secondary to that.
Yes.
Keep going.
We have one, got a 2.
Got a 2. Great thought, Con. Very nice. ITK and MAG-T1, so thinking about the EBV susceptibility. Absolutely, Shan. Yeah, that's a good spot. Got another vote for RAG from Nikita. Really nice ideas, everyone. I'm going to let Carolina tell you the reveal. And, oh, more RAG. I'm going to let Carolina tell you the reveal. I think I was very surprised, so I think other people will be too. Go ahead, Carolina. Tell us how it all plays out.
So we have a patient with all the phenotype, lab tests, and the clinical phenotype that I presented. I should tell you here that after he presented with the lymphadenopathy that we have a RT-PCR positive for EBV, he also presented another one that was positive for CMV. So he had both EBV and CMV. And also he had the physical malformation with an acrosyndactyly and absence of two toes on the foot. So when I first met this patient, I first thought about a chromosomal abnormality. And then I decided to study for deletions and maybe find a gene responsible for his immunodeficiency inside this deletion, and also went for exome sequence. So when we did this approach for the CGH, we even didn't, we sent the samples to the CGH, but then we got the exome sequencing results first. And we found a single nucleotide substitution at a splice site for the PIK3R1 gene. It's exactly the same position where the patients started being described since September 2014. So we have a paper that Tamara is one of the co-authors. I think it was the first one. And also we have another paper from a French group presenting a few patients with this mutation. Later on, we also had another paper presenting 3 other patients, and all the patients with mutations in this gene with primary immunodeficiency presented this exactly same mutation. Sometimes G was replaced by A or T, and in the case of this patient, the G was replaced by a T. And we sequenced using a Sanger sequencing, and we proved that the mutation is there. So we have a heterozygous mutation, and both parents do not have the mutation in this gene.
Go ahead.
Hello? So would you like, yes?
Go ahead.
So anyone would like to comment?
Do you have a couple more slides, Carolina?
Yeah, I have one more slide. It's this one here. That's the help that I'm gonna ask for you. And he has, so someone is asking here, I think it's Saul, is asking about bronchiectasis. Yes, he does present with bronchiectasis. IgG subclasses, it's all, they were very low, and after I started following him, he was on IVIG replacement, and I couldn't check it exactly how it is.
That's an amazing story. Tamara, you have some experience with this type of disorder. I wasn't surprised by the low B cells, but I was a little surprised by the high IgM. Is that a common feature, or just perhaps reflecting this patient's infections? How consistent is this patient with the general picture? I think Tamara has a cold, so she muted herself. So let's give her a minute to
she did.
mute and see if she can respond. Tamara, are you there? Oh, maybe she's having a coughing fit. Carolina, is this patient very consistent with other PIK3R1s?
Yes, so for example, for the patients from Tamara's paper, one of the patients, they didn't have the information for for the immunophenotype, the CD4 and CD8 and B cells, but most of them presented with low CD4 and a higher CD8 and low B cells. But I think they are they are not very consistent in clinical phenotype.
And what about the lymphoma component? How frequently do you see lymphoma?
Yeah.
Entry and exit chimes are on.
Yeah. So I think Tamara is on. Tamara? No. Okay,
Entry and exit chimes are off.
Hello. So for the lymphoma, we have a few patients that developed the lymphoma, and one of the patients from Tamara's paper, actually he presented with recurrent lymphoma, not even only one, once he developed lymphoma.
So that's a big part of the phenotype in this syndrome.
Yes. Yes, Tamara, we cannot hear you. She wrote here that the answer to the IgM is that I agree that it was infection-related stimulation.
Okay. Let's go ahead. You had a couple questions about management. I think we should tackle those and then move on to Michael.
Okay, so now the patient is like not completely free of infections. He still have ear infection, very difficult to control. So 2 weeks ago, he underwent a surgery to try to clean the infection, and he's doing well. I was very afraid of when he went to surgery, but the physician, the surgeon, told me that it wouldn't be a very open surgery, and we took all the precautions with giving him immunoglobulin and giving him a higher dose of antibiotics so that he could be protected, and he went well. But I feel that I don't know for how long we'll be able to. Hello?
This is Tamara. Can you hear me now?
Okay, yes, now we can.
Oh, good. I'm so sorry. I thought you could hear me coughing at the beginning. I'm not sure what happened. What I wanted to share in terms of the IgM, but also the cancer risk, is that I do think that the IgM was from infectious stimulation, because one of the younger patients that was presented in the series had a low IgM. And what was striking was our patient always had low B cells as well, and he was diagnosed with CVID. But then he got insane lymphoproliferation of his cervical lymph nodes that were CMV positive in his case. He never had EBV disease. But then we learned that his mother had EBV-driven lymphoma and had undergone bone marrow transplantation. So this is, I think, one of the commonalities. But what we did with ours, and I'm sorry I missed a little bit of the management discussion, is before we knew the causative mutation, we started him on rituximab because he was already so hypogam. He did not have many circulating B cells, and so the downside of that seemed quite low, and he responded beautifully. And he's done incredibly well, and interestingly, the CD4 lymphopenia has also improved over the last couple of years, and I cannot tell you why that is. But I think the ideal treatment would be a treatment that targeted the catalytic subunit, because all of these people with the mutation in the regulatory subunit, even though there's not very much there, also have overactivation of the P100 subunit, like the first Pasley patients that were described. So I think rapamycin makes sense that it's downstream of P100. We had good luck with rituximab. And our patient is not really a transplant candidate, but his mother was transplanted after her Hodgkin's diagnosis, and she's still doing quite poorly. So I don't know if the other patients have been transplanted. There was a 30-year-old woman who was in that paper, and a 5-year-old Chinese boy in addition. So I don't know updates on those two.
So I guess I don't know what the right answer is. I want to open up the discussion so that people can vote on the therapy here. Of course, it's a very individual decision, and the patient in the end has to pick what works for them. But I guess I'd be a little nervous about long-term rapamycin with knowing that there was this pre-existing viral susceptibility. You never know if that might be improved on rapamycin, not worsened, but I suppose there's the potential. So let's just get people to sort of chime in and say what their vote is for therapy in this, just to kind of get a sense of what people are thinking. I understand there's no right answer. Carolina does too. But just out of curiosity, there's no natural history data. We don't really know. And Tamara, Carolina's patient sounds like he might be a transplant candidate. Would you favor that for him since his end organ damage is, it sounds like, relatively mild?
Yeah, I think that he certainly sounds healthier than our patient. And I think that one of, when you were saying rapamycin long-term, thinking about the infectious risks is one thing, but the flip side of that is a lot of patients are in PI3 kinase locations, for example, this area between the two H2 domains that are associated with other malignancies. So even if we're treating downstream sort of the autoimmunity and the lymphoproliferation, if he still lives with overactivation of PI3 kinase, we're not helping him with his cancer risk and, sort of going towards a lymphoma. So, does rapamycin inhibit that signaling a little bit more? Like transplant would be the cleanest if you didn't have a P100 inhibitor, which I know that they're studying. So I think for your patient, he's healthy if you have a good donor, given all of the things that can develop over time, and he hasn't even had all of them. I think going towards transplant makes sense. The other thing that I would say in terms of diagnostics for people who may have patients like this is, unlike the people with Pastley and the catalytic mutations, people who have the regulatory subunit mutations have more inflammatory disease. So inflammatory bowel disease, juvenile arthritis, multiple autoimmune cytopenias. And so I like the title of the perfect immune deficiency, but it's also kind of the worst of the worst. If you have immune deficiency, you have immune dysregulation, you have, precancerous tendencies. So if you can transplant, and I agree with Alex, what she just wrote, I think that, rapamycin in the meantime makes sense, and maximizing, trying to keep him safe. The other last thing we did was we had our kid on antivirals, even though there's not great evidence that helps with EBV or CMV. We did that at a point with his lymphoproliferation, and it did seem to help.
Yes. So the patient, he doesn't have any siblings, so we are waiting for him to find a match donor, and it was our first thought for his treatment, actually. So we will consider now to start him on rapamycin while we look into the transplant. And I discussed the patient briefly already with the transplantation group here in Curitiba, and their concern is that it's shown that the patients have short telomeres on CD8 cells, right?
Yeah, exactly. It's premature.
Yeah, and what they say is that we should be careful about the chemotherapy that we give to the patient before the transplant because of this. So we are trying to study and to check if our patient also has this short telomere. So I see that Juliana Fernandes is here with us. So, and I know that she works with transplant, so maybe she has some considerations, or anyone else, I don't know.
All right, thank you both so much. We're running a little bit late, so I always hate to cut off the discussion because I think that's really, really valuable. But I think we should move on to Mike Keller's presentation. We had two people vote in from Mexico, Saul and Francisco, who recommended transplant. I think other people are leaning that way, but of course, it is really difficult. Each family is their own unique equation, and it has to be tailored to what their needs and desires are. So, Carolina, thank you so much for this presentation.
Thank you.
It was a great case. to hear about.
Okay, thank you very much.
Jesse, can we pull up Mike Keller's presentation? Oh, thank you, it's right there. So our next presenter is Mike Keller, and our next mentor is Alexander Freeman. Mike, go ahead and get started. Oh, Mike, your microphone is off. Now you're ready to go. Okay.
Hello, everyone. Good evening. So I'm happy to be able to present this case to you. So Dr. Sullivan has labeled this, where are the cells, why are they missing, when do they vanish? So this was a 14-year-old with congenital heart disease and chronic neutropenia who came to see us in clinic. So he had quite a bit of background.
Up a little bit.
Can everyone hear me okay?
That's better, yes, thank you.
So this is a 14-year-old who had congenital heart disease and came to see us due to chronic neutropenia and recurrent infections. So he had atrial low with absent pulmonary valve that was repaired in the first year of life, and right off the bat had been noted to have chronic leukopenia with neutropenia, with the neutrophil counts ranging anywhere from 500 to 2,000. So he was placed on GM-CSF from ages 1 to 4 years of age, improved, and seemed to be doing relatively well, and actually had a lot of bone pain. So he ended up actually discontinuing it at 4 years of age. And based on both his heart disease and his chronic leukopenia, he was clinically diagnosed with DiGeorge syndrome. However, the family had reported that he'd had a microarray at a previous institution that did not show any microdeletion. So subsequently at age 6, he had thrombocytopenia and was diagnosed with ITP and treated with immunoglobulin and responded. And at that time, due to his chronic leukopenia as well as the new thrombocytopenia, he underwent a bone marrow biopsy. And at that time, apparently, it was read as normal. And then, so between 6 and 13 years of age, he was relatively well. He had roughly annual respiratory infections, but nothing serious until at age 13, he developed a respiratory infection with severe myalgias and arthralgias. This is in his home country, and it was diagnosed with dengue fever. So he was hospitalized and recovered, but every month thereafter, and this was in the summer of 2014, and every month thereafter for 6 months, he was developing monthly severe respiratory flares or pneumonias. And that fall, he had a chest disease, which showed bronchiectasis, most notably in his right middle lobe. So that is what brought him to our clinic.
So, Mike, were those pneumonias thought to be viral or bacterial?
So that is a good question. Apparently several of them were chest X-ray proven, but we don't have causative organisms on those prior pneumonias.
Okay, let's just take a pause here. So this is a little bit of an unusual. Here we've got a cardiac anomaly. We've got ITP. Certainly significant recurrent cytopulmonary infections. We don't see a lot of dengue here, so I'm not sure what to make of that. I think it may have been some bad luck and bad bronchiectasis. So what are people thinking? So Carl wants to know if there was a thymus.
So that is a good question. I do not have the operative. He was actually treated in Miami when he was a baby. I don't have the operative report from that, but and again, he would have been in the pre-Trek era, so it's unclear if he had a thymus up front.
Okay, and Saul, I think, is going down the charge pathway. Any other malformations other than the cardiac anomaly?
Great question. So no, he didn't have any notable skin findings and no GU malformations. And anti-neutrophil antibodies, I'll definitely get into that in a short bit. CH50 was not checked at the outside hospital, but we'll get into our immune workup shortly. Let's see. Adverse reaction to vaccines, none that we know of. And no visible veins, that's interesting, or prominent, that's interesting, very interesting idea. Nothing notable on exam in that regard.
All right, nice ideas, everyone. So go ahead, Mike.
So his family history was pretty unremarkable. He had one older sister who was well. Family is actually from El Salvador, so they're fairly well-off family, so that he got most of his care in the U.S. So when we saw him age 14 on exam, his height and weight are both below second percentile, but that said, he didn't have, I wouldn't have classified him as growth failure, as he was a short but relatively well-developed adolescent. He had really no striking dysmorphisms. He really didn't strike me as having very typical DeGeorge facies, for that matter. He did have the pulmonary flow murmur with a systolic click from his repair. The only other really notable exam finding is that he had splenomegaly to about 3 centimeters below the left costal margin. But he had no hepatomegaly, no adenopathy anywhere else, really nothing else that's striking on exam.
Does this make anyone want to change their mind? There's not too much more here, but the splenomegaly I think is significant. Does anyone want to change their mind? Nope, people are stumped, Mike. You're going to have to take us through a few more clues.
All right, so here is our lab workup. This is again age 14. So everybody process this. And then the obvious notables, he's quite leukopenic with kind of a relative thrombocytopenia, but a fairly striking neutropenia. His ANC is 90. His total immunoglobulins are notable for, and I apologize, that second immunoglobulin should be IgM. His IgM is normal, but his IgA was undetectable. His total IgG was fine, and his quantitative, so his antibody responses, tetanus, diphtheria, and pneumococcus, were all fairly intact. And again, he hasn't had IVIG since he was 6 years old. Flow cytometry, on the other hand, was somewhat striking. So he has T-cell lymphocytopenia, and most notably has a low CD4 subset and low B cells.
That's pretty impressive flow. So, Mike, I would summarize this as being a lot going on here. So the platelets are a little low, the neutrophil count is awful, the lymphocytes are low, and the B cells are pretty punky. So folks are starting to chime in here. We've got some A-GATA2. Francisco's worried about autoimmune. We're still hanging there with G6PC3 deficiency. Shan has come up with dyskeratosis congenita. Very proud of you, Shan. Not many people think of that. Tamara wonders if this could be secondary to infection. Other thoughts out there? All right, Mike, keep going.
Right.
Wait, we've got a Fanconi. That's an interesting thought. You're probably a little closer than you realize. All right, go ahead, Mike.
Certainly. So with regard to causes of neutropenia, typical things we think about, I mean, the way I usually try to classify it is either production, trafficking, or consumption issues in terms of neutropenia. So production issues such as, I mean, we've had some people mentioning a lot of congenital causes of either severe or cyclic neutropenia. So that certainly is a possibility. This child was very highly responsive to GCSF. And then trafficking defects, and lastly, consumption. And certainly consumption, be it either autoimmune or hemophagocytosis, was kind of one of the primary things on our mind initially, given that he had splenomegaly and he had a recent history of ITP.
Go ahead.
Should we move on, or are there any questions? I think Dr. Freeman is trying to get on.
Okay. Alexandra,
So,
your microphone is on the computer, but you may need to phone in just to be sure you've got a good connection.
in the meantime, so Dr. Sewell at
Do you have any? Can you help Alexandra get on?
Yep, I just sent her a message. If you click on more and then the audio options there, it should help.
So, Mike, why don't you, there are a few people asking questions about what does neutrophils look like, things like that. You want to field those while we're waiting for Alexandra?
So this indeed is not his peripheral smear. Although I can probably give away the fact that his peripheral smear, though it likely would look, it would probably have very few of them, that neutrophils would in this case would have looked relatively normal in the peripheral blood, what few of them he had. I think Ben Sewell asked whether.
Credit to Ben Sewell, who suggested looking at the neutrophils. So everyone take a good look at these neutrophils. Why do they look different? I know you see that they're different, but put a name to why they look different. Yeah, absolutely. They're hypersegmented. So how are we doing with Alexandra? We're still working on connecting her up. So let's go ahead. They are hypersegmented. So now can you name an immune deficiency associated with hypersegmented neutrophils, not hyposegmented, hyper. Can you name an immune deficiency that seems to fit this? More thoughts? Megaloblastic, nice idea, yeah. Jesse, I think you need to help Alexandra a little bit more, and you may need to. All right, we've got great ideas there. Chadiakagashi, Whim, B12 deficiency.
Oh, I think I can talk.
Alexandra, welcome.
Sorry about that. Okay. Sorry. Now I've been too focused on trying to figure out the website. Okay. Wait, and did we talk about, that he also has a combination of the hypogam with the funny-looking neutrophils?
So one person has clued into that, but I think let's give other folks an opportunity to clue into the hypogam plus the hypersegmented neutrophils.
Yeah, just going back that, the initial presentation was more sign of pulmonary infections with the neutropenia. And that it was a pretty striking low level of B cells that we found. This is 9.
All right, Mike, go ahead and forge on.
All right. So 2 months. So following this workup, I'll tell you. So we had sent off some additional testing. Sequencing was cooking, and we suggested he go back onto GCSF. 2 months later, we get a call that he's lost vision in his right eye, and we scrambled to get to an ophthalmologist, and this is what they see. So so you see on the right side, there is what we would describe as kind of white focal retinitis with overlying vitreous kind of inflamed vitreal background. I think what the pathologists would usually call this headlight in a fog. So
I think we should give the diagnosis, because otherwise we have flashbacks to pediatric board.
He had a vitreal CR done and confirmed to have retinal toxoplasmosis.
Does that broaden the differential for anybody? I think this one's hard to bring in, with toxoplasmosis outside of HIV, where you see a lot in immune deficiency. But any other thoughts about, what would predispose someone to toxo? Good to described sometimes in CD40 ligand deficiency, but nothing else about the case makes sounds like that at all, kind of along that pathway. But it brings in more of kind of a T cell flavor, right? In addition to the B cells. Okay, why don't we go on?
All right. So, well, the last slide actually gives it away. So we've had a. Yeah, sorry, but
we're getting a couple more things. Yeah, and the differentials being expanded to WHIM also here now. MHC class 2.
WHIM, and then class 2 deficiency.
I think that too is a good thought, always with the lack of B cells in the neutropenia, but presenting the right in infancy would be a little bit unusual.
Does anyone actually think this is just to George?
No.
Not either.
And please don't say just to George.
Well, yeah.
Right, why don't you go ahead and reveal the diagnosis, and then we'll have a little conversation about it.
So well done to the folks who said WHIM. Indeed, we did targeted sequencing, and he had a heterozygous nonsense mutation, the most common type in CXCR4. So a truncation mutation of the C terminus. That's the regulatory domain. So it's a gain of function mutation that causes. So in his case, it explains his neutropenia. It explains his lack of B cells and also his recurrent infections. The only thing that was new in this case was that toxoplasmosis, to my knowledge, has not been described in WHIM syndrome before.
Not that I know of either. I mean, I think it's been more, kind of an hyper-IgM type syndromes.
He obviously did. It may have been partly his exposures since he was from Central America, but
And did he have warts?
He did not have any warts. Nope. And for that matter, really, when we saw him at age 14, he really didn't have striking hypogam. Just IgA deficiency.
Yeah, and the low B cells.
And the low B cells, certainly, at least in the periphery.
Yeah, it's really interesting. And how about the parents? Were the parents mutation positive, either of them, because it's autosomal dominant?
So that I'm not sure of. We had sent him to David McDermott, and I'm sure that the parents have been sequenced, but I have not heard the result as of yet. But they're both well. So I am kind of suspecting that it's probably spontaneous in him. But so there's a question about the bone marrow biopsy. It is an excellent question. We were not able to actually get the slides, but our suspicion was that probably even at age 6, when he had the bone marrow biopsy, he probably would have had some neutrophil abnormalities that were subtle but visible.
Mm-hmm.
So people have raised a couple good questions here that I hope Alexandra or you, Mike, can answer. One is about the ITP, which does seem to me to be a bit of an outlier for WHIM.
That is a great question. So not entirely sure, it seemingly responded to immunoglobulin, so probably was indeed autoimmune. So no, that didn't entirely fit.
Yeah, I hadn't heard about it either with this. It's an interesting question about for toxa, the T cells and the neutrophils getting in the right spot. Kind of the question then would be, would you also see it in GATA2 deficiency with toxa? But I don't think of autoimmunity as being very common in WHIM. I mean, this patient's a little bit unusual. It's interesting the comment about tetralogy of Fallot, too. I hadn't realized that.
Yeah, I want to give a shout-out to Milica from Rome, first of all, because I think it's 3 in the morning where you're at. And second of all, I had recently reviewed the WHIM literature, and until then, I was not aware of the association with cardiac anomalies. So, Milica, thank you so much for pointing that out. I think it's a feature that's not very well publicized. So nice job. And I think one last question for both of you. Joyce asks, what makes the neutrophils hypersegmented? And I know it's a little bit of a long story, but if you could just give us some insight into why they look so peculiar, that would be great.
Alexandra, if you don't mind, I will defer that one to you.
Although I know a little bit about LIMS, why they look so funny, I think, the problem, I'm not sure why they look so funny. You think of this as the myelocathexis, and so the neutrophils are getting stuck in the bone marrow. So the problem is kind of the release of the neutrophils to the marrow. And I think it's something about that, the fact that the maturing of them is happening and kind of getting stuck and kind of stagnated there in the marrow is why it happens. But I don't know if I can be more eloquent than that, but I think it has to do with that, the myelocathexis.
That's my limited understanding as well. And then I'll make just one more point. I did go to a WHIM lecture back in the early fall, and they made the point that you can really have a significant amount of pancytopenia in WHIM syndrome, which, again, was another feature that I wasn't that familiar with. And so that wasn't true in this case. Mention it.
Yeah, and I think that's been true. And what's been kind of interesting about that Perexifor trial is that I do think, I think especially because of the name, we all think of the neutropenia, but, or kind of when you think of the classic kind of association. But, often the NK cells are low, the T cells are low, a lot of the different, white blood cells are low in the periphery. And so that's what kind of makes Perexifor so interesting compared to GCSF. Because with GCSF, you were seeing the neutrophils were coming up, but you weren't really seeing that much of a change in terms of the warts and, the kind of the abnormalities that are more because of the lack of, circulating NK cells and lymphocytes. So with the Perexifor, which is kind of like the custom-made thing, for this disease, although, obviously that wasn't why it was marketed, but, that they're seeing not just increases in the neutrophils, but also seeing increases in the T cells and the NK cells. The other thing was, you said with this patient, he had a lot of bone pain with GCSF kind of early on. And I think, they've really, I think in part because of this defect and kind of the myelocathexis, that, these patients really have had trouble tolerating, I think a lot of them, GCSF. And the Perexifor has actually been better tolerated for them in terms of the bone pain and the other symptoms. The problem is, it's incredibly expensive. It's kind of a long-term therapy. But the results, the picture, there's been a couple, not this new trial looking at GCSF, but compared to Perexifor, but just the kind of, using Perexifor in the papers that have been published. I've seen some of the patients just on our rounds. The warts response has really been amazing.
Thank you for sharing that. That's really impressive.
WASP.
Yeah.
So we didn't do whole exome on this patient just because we got a hit initially. But then it's an interesting thought about whether you might have a blended phenotype. Maybe perhaps happens more often than we think.
I would think with WASP though, he had the ITP that responded though. He said, that the platelets actually then came up also, and the bronchiectasis and everything else goes along with it, and the cardiac defect that was pointed out, and I think, I think it's probably just that, and it's just kind of an interesting presentation.
Mm-hmm.
All right, I think we're going to tie it up. We're a little bit over. Many apologies on that, but I didn't want to cut off the excellent discussion. I think these were two amazing cases, really,
they really were.
Lots of insights, and I thank both presenters very much, as well as the mentors who brought amazing perspectives. So thank all four of you very, very much, and thanks to the audience who contributed and was so participatory. So have a good night, everyone, or in the case of the people where it's morning, have a good morning. And we will have, this is it for December, but we will have a case webinar in January. Remember, if you have any cases, to please email Joyce or myself, and we'd be happy to include you on the list and get more cases in the queue. So thanks, everyone, and have a good night.